she'll be having some issues.
Yeah. So a very good evening to everyone who's joined. I see the numbers are rapidly rising, but you want to start the session on time. So I welcome everyone to today's webinar on deliberate self-harm in adolescents. Um, since we are joined by our president of West Zone, Dr. Sudhir Bhave, I would like to start by asking him to say a few words.
Thanks, Neha. I think it's again a great pleasure to be online with this Women and Child Mental Health Committee. I must say that for the past 3-4 months, I mean, ever since the committee has taken over, they have been doing a great job. And very regularly, every single month, we have been having very good topics. So I must compliment Dr. Ritambara and her team for that. And today, we of course have a very eminent person in the form of Dr. Shreyoshi Ghosh. So we welcome Dr. Shreyoshi to West Zone, and we also welcome Dr. Isha Sharma to the West Zonal meeting. Yeah, so wish you all good luck. I'm sure the program is going to be loved by all. Over to you, Neha.
Thank you, sir. So we are lucky to have two of the brightest stars in the galaxy of child and adolescent mental health with us today. Today's speaker, Dr. Shreyoshi Ghosh, and the chairperson, Dr. Isha Sharma. So without wasting any time, I would hand over the mic to Isha ma'am and ask her to introduce today's speaker. Ma'am, over to you.
Thank you, Neha. I believe you have a slide on Shreyoshi. Would you like me to refer to that? While that's coming on, a very good evening, everyone. It's a delight to be here. And I was, in fact, pleasantly surprised when Ritambara ma'am called and said that I have the wonderful privilege of being a part of this and then chairing Shreyoshi's presentation. So gives me great pleasure to introduce Dr. Shreyoshi Ghosh to the group. She is currently consultant child and adolescent psychiatrist and psychotherapist in Bangalore at Empower and Kadabam hospitals. She, of course, is one of our most prized alumni of the DM Child and Adolescent Psychiatry program at NIMHANS, and I've had the pleasure of working with her in the department. Her areas of interest, of course, span child and adolescent psychotherapy, adolescent suicidality, suicide prevention, and infant and preschool mental health. Not surprised that she had the Institute Gold Medals for the best outgoing students of her MD and DM batch, as well as several international awards for research work and stuff that she's presented abroad, including the Helmut, I don't think I can even pronounce that, Remschmidt Research Seminar Fellow, I hope that's correct, and a Child Seminar Fellowship Award in Rome, and a Chevening Scholarship recipient in 2015. So she does have several different publications in different areas to her credit, and it's always a learning experience interacting with her in any clinical or academic context that we happen to cross paths. So with that, Shreyoshi, I invite you to please start your presentation, and I hope that we will have some good Q&A at the end of it. Welcome, Shreyoshi.
Ma'am, I'm so sorry. Can I just jump in? But I forgot to introduce the chairperson. So I will just...
Don't worry about that. I'll just finish that up in one line. I am Isha. I work at NIMHANS. I'm associate professor in child and adolescent psychiatry. Thank you. Let's start. I think we're all waiting to hear from Shreyoshi. Please go ahead.
Okay, and ma'am, I would just like to add, this is for the audience, that Dr. Shreyoshi has prepared some questions for the audience, and we would love it if you would interact with us by typing the answers to those questions in the chat box. So I will periodically keep putting these questions up in the chat box, and then once the session is done, our chairperson will kind of sum it up for everybody, and then we'll hopefully have some time in the end for audience question and answer as well. So Shreyoshi ma'am, please start today's session.
Thank you so much, Neha. And, I think, yeah, we shouldn't have missed Isha's introduction. She, as she said, it's been such a pleasure working, with her the time that we were at NIMHANS. And I was actually thinking of her when I was preparing some of the slides. We used to have a psychotherapy group, if you remember, and so much, of the work that we do with adolescents who self-harm involves psychotherapeutic intervention. So that was really like great moments that we had spent together. And Isha is like a fantastic researcher in addition to being an amazing clinician. So she wears all of these hats in the department. That's a terrible introduction, but it's just a little bit. So I will share my slides. Just please give me a moment while I do that. Neha, is this visible?
Yes, ma'am.
Okay, okay. So after about maybe 30 to 40 minutes, if I've still not wrapped up my talk, would you just give me a nudge so that we have at least 15 to 20 minutes for discussion at the end?
Yes, ma'am. I'll do that.
Okay, sure. Thank you.
Thank you.
So the topic, the way that I've thought about it today, is that, I'll just give you a quick overview of some of the things that we need to know in terms of like definitions. What is the current nosological status of NSSI or DSH? What are some of the trends that we are noticing? I mean, there's a lot of conflicting literature, but are there some things at least that we can pull out that really seem to be the emerging and evolving trends? What are the links between self-harm and suicide? Right. So this is something that has, a lot of researchers, clinicians have been grappling with. Like, so, what is the pathway? How do things progress? And then, of course, I want to spend most of, my time today really speaking to you about intervention, and kind of letting you know how are the ways in which, different clinicians have approached intervention to an adolescent who is self-harming. As a part of that, a little bit about the functional analysis of self-harm and the psychotherapeutic interventions, and just a brief note about pharmacotherapy, because as many of us would be aware, there isn't really like a lot of evidence base for pharmacotherapy if you just look at NSSI or DSH as a construct. Um, and as Neha mentioned, we will be having a few audience questions. So this is something that Ritambara ma'am suggested, and I think it's a good idea. So basically, I'll be projecting, some questions, and then Neha will type those out in the chat box, and you have some time to reflect and ponder over those, and give us your responses, and we'll try to sort of collate things at the end, and see, as a group, really how we're thinking and conceptualizing self-harm in our practice today. So DSH is essentially deliberate self-harm. NSSI is non-suicidal self-injury. And so these are kind of used interchangeably in the literature. NSSI has been included in DSM-5 under the section on conditions for further study. This is kind of an important definition because a lot of researchers, are trying to use this when they study NSSI or DSH. So essentially, what they're saying is that it's intentional, self-inflicted damage to the surface of a person's body with the expectation that the injury will lead only to minor or moderate harm, and there is no suicidal intent on 5 or more days in the past 1 year. And of course, the key difference between this and a suicide attempt is in the intent to end one's life. So, if there is a 14-year-old who, had an intent to end her life, and she just perhaps took a small quantity of, say, paracetamol, and thought that it would, sort of end her life, then that essentially is a suicide attempt. Whereas somebody who took a much greater quantity, but just took it with the intention of alleviating whatever, distress that was internal, or with, some sort of a interpersonal, kind of a motivation to the attempt, that would become a deliberate self-harm attempt. So it's not necessarily like exactly the potency of what they're doing, but what is the intent really in behind the action. So there is a really nice book that I researched on suicide and the perspectives from India by Dr. Sujit Sarkhel and Dr. Lakshmi, and there they have one chapter which is specifically on NSSI. So there aren't too many research studies, but the few that they have found where they felt the methodology of the study was more rigorous, and they had actually taken like a proper definition of NSSI when they would studied it. So in those they found that approximately like lifetime prevalence was about 31%, which is higher than what is actually reported worldwide. And the average age of onset also is in India is 15.9 years, which is also a little bit higher than what has been reported in the worldwide literature. What the trend has been that it often continues into young adulthood, although the frequency tends to decrease, but it's not really a behavior that tends to kind of be very sort of time limited, or to just kind of last for a few weeks. The trend is that it tends to continue. And in India, the gender differences do not seem prominent. That's what the current literature is telling us. So earlier, studies would tell us that there is a female preponderance, but now that is not so evident. And certainly, like if we compare previous generations, then now, the prevalence rates are on the rise. And what is theorized to be contributing to this is the increased exposure to the internet and to social media. And there's some research also supporting this, that the odds, even in Indian adolescents, that the odds of somebody actually engaging in self-harm is higher if they have access to the internet and social media. So we have like some audience questions that we can kind of think about at this point, which is that in your practice, what is the clinical course that you have observed, and how quickly have you been able to bring down self-harm? And do you find it helpful to target it as a treatment goal? And why I felt that this is something that we could think about is that, so many times parents come to us and they sort of want, like a quick reduction in self-harm, right? Because, the school would have noticed it, and there would be so much anxiety in in the parents' mind. But is that really how we have seen that in practice? And if any of you have seen it in that way, then what are some of the other contextual factors that you have noticed? So this is something that I thought that we could think about. So when it comes to the pathways to self-harm or suicide, they self-harm or NSSI, DSH, it shares a lot of the common pathway to suicidal intent or a suicide attempt, right? So when it comes to genetic, biological factors, which would then predispose someone to develop a psychiatric disorder. So typical psychiatric disorders that we do need to consider, especially linked to NSSI, would be, of course, mood disorders like depression, a personality vulnerability like borderline personality disorder. So to really look at, if there are psychiatric disorders that are predisposing, in combination with negative life events, in combination with some personality factors like perfectionism or aggression and impulsivity. And then, when an individual has developed, hopelessness, if then what are the sort of methods that are available to them to reduce the psychological distress? And if they if they have lethal methods that are available, then the outcome may lead to suicide. Whereas if there are non-lethal methods, then it may be self-harm. But it's kind of theorized to be a shared sort of a pathway. And which is also why when we look at the links between DSH and suicide attempts, it's important to remember that DSH or NSSI is considered a gateway to suicide by many theorists. One, because the shared pathway, the shared vulnerability is definitely common, and somebody who self harms how we think of it is that a behavioral threshold is crossed. That's how, in the Rutter's textbook, how they speak about it. So, and once that behavioral threshold is breached, then the individual, then one can conceive that they can then continue to sort of harm themselves, and that it may progressively get more and more severe. And there's quite a bit of research that individuals with NSSI are in fact at greater risk of having suicidal ideations and acting on them with the acquired capability that they have to indulge in painful and lethal methods. So this is something that has been proposed by Thomas Joyner. This is his interpersonal theory of suicidal behavior, where essentially somebody with non-suicidal self-injury now has a lower fear of death and an increased pain tolerance, which may actually sort of act as an enabling factor and sort of predispose them to suicidal attempts. And together with that, these two constructs of, being burdensome, to others, self-hate, and a sense of loneliness and not belonging. So all of these, can definitely link NSSI to suicidal attempts. Moving to assessment and interventions. So somebody presenting with NSSI, of course, one needs to see if they need any medical or surgical attention, because they often do. If that is not required, then a detailed mental health assessment with a special focus on suicidality. So like a detailed risk assessment to really look at passive death wishes, active suicidal ideations. Have they thought of a plan? Have they set a date? One question that I find helpful to ask is, if somebody says that they are having active suicidal ideations, then to check with them, well, in the next, few weeks or so, what are the chances on a scale of 0 to 10 that you feel that you might actually make an attempt on your life, where 0 is not likely to make an attempt at all, and 10 is, it's definitely going to happen. And that kind of really does give an indication of, how strong the suicidal intent is. Of course, looking for comorbid mental health conditions, and it could be really anything. The most common is depression and personality vulnerability, like youngsters with especially BPD. But if all of the other disorders, whether it's post-traumatic stress disorder, whether it's eating disorder, all of them can have comorbid NSSI or DSH. I think one condition that has been highlighted in ICD-11 that's also important for us to consider is complex PTSD. I thought later that I should have put a separate slide on that, because when I was thinking about my own patient population with NSSI, so many of them now would actually fit the ICD-11 complex PTSD criteria. Then, of course, whether there are other forms of self-injury or self-harm apart from what they've presented with, what is the method, what is the function, which I will expand a little bit on later, and what are the inter or intrapersonal factors. If there is active suicidality after the risk assessment, then that would need, of course, very targeted management, ideally in an inpatient setting. If that is not there, then to really look at, treating any of the, comorbid mental health disorders, starting psychotropics if that is indicated. And if it is, if we are not finding, that somebody is sort of clinically depressed, or somebody has, an eating disorder that meets criteria, then if we are just looking at NSSI, then it is more non-pharmacological interventions that really would be the mainstay of management. So this is a little bit about the functional analysis of NSSI, and this slide and the next are taken from the ICAPAP textbook, which I found is a very useful resource, especially for those kind of, starting out in child psychiatry, just starting to read and know about child mental health. So it's important as a part of the initial assessment to really look at what function is the self-harm serving for this particular individual. So so all of the functions on this slide have reasonably strong evidence, whether it's affect regulation, whether it's anti-dissociation, anti-suicide, interpersonal boundaries, interpersonal influence, self-management, or sensation seeking. In my own experience, I have not seen the sensation seeking component so much. Self punishment, definitely so. Anti suicide, anti dissociation, affect regulation, these are ones that I encounter very commonly. And sometimes it's not just one function, but we'll find that at different points, a person is engaging in self harm or self injury with different functions. And I'm also, at this point, I know that a lot of the times we get asked by the teachers, by parents, well, is it attention seeking, right? Um, I think we need to be careful with how we really, reflect on and answer this question, and because I would prefer to look at it as somebody who needs attention rather than, is really seeking attention, in a sort of a histrionic kind of a way. So that's my own sort of personal thought on that aspect of it. This is something similar, it's just conceptualized a little bit differently by Nock and Prinstein. I remembered that my teachers had sort of emphasized on this 2x2 table, so I thought I'd put it here. It's largely similar to what was there in the previous slide, but it's just kind of arranged nicely in terms of whether self-harm is serving as positive or negative reinforcement, and whether it's in the intrapersonal or the interpersonal domain. So at this point, one audience question that I thought, that we could sort of think about is that how helpful do you all find DSM or ICD diagnostic systems in the management of young people with complex presentations that include NSSI, especially when the NSSI is kind of at the forefront, and parents, teachers, all of them want us to sort of, make that as a treatment goal. Um, you know, how do we really write this in our diagnostic systems if they're not meeting criteria for moderate to severe depression, or so how do you sort of tackle this, and how can we really think about this, and especially when we're sharing diagnosis with parents, like how do you really present it to them is something for us to think about. So moving on to the psychotherapeutic interventions. So I'm going to be talking about the ones that have some evidence base, and starting out with more of the skill-based sort of interventions, and then moving on to interventions that have developed more recently, and some of the psychotherapeutic modalities that I will be talking about, I do have some training in myself, and some I've kind of read about, and try to understand to see if I can incorporate some elements in my practice. So the Cutting Down program is essentially a CBT intervention developed for adolescents engaging in NSSI. So this is one that was actually used in a PhD thesis that was done at NIMHANS, and the student who used it did find that there was some reductions in self harm behavior. So it's of course targeting self harm in terms of the frequency, in terms of the intensity, and looking to bring it down with a typical kind of a CBT framework, starting with psychoeducation and CBT techniques, problem solving skills, emotional regulation strategies, and behavioral activation and relapse prevention. This is one that Rutters sort of speaks about. So it's the UK group developed by Dennis Ogren. There is a nice YouTube video where he speaks about therapeutic assessment, and how he speaks about it is that so the central theme here, where which leads to this sort of downward spiral, and is what Dennis Ogren calls core pain. So that I am unlikable, I am not good enough, and that this is often evoked by the boxes at the side, like, a feeling of being abandoned or a feeling of being rejected, which he calls reciprocal roles, and how that can then sort of have this, cascade wherein, and which can be sort of amplified or magnified by, substance use, by, smoking cannabis or alcohol, and then leads to cutting, which then we know are going to have, certain long-term consequences. The person is going to feel guilt and shame, and the feeling of feeling better is just, very transient. So this is how, even in the initial assessment, he has spoken about just mapping this out, and then looking at what are the exit points from this cycle. So he conceptualizes that at every point in this cycle, it is possible to look at, how to break it. And he does say, when he talks about this, that this is, a very ideal sort of, moving a person, to this point where, so many things have really changed in the cycle. But to start out with, to really look at which of these points we might be able to interrupt the cycle. So this is kind of similar to how DBT conceptualizes interventions for self-harm as well. Like, they do speak about a chain analysis where, the problem behavior is, of course, cutting, but then, what are the vulnerability factors that the person has? What are the prompting events? What are the thoughts? What are the feelings? Is there shame? Is there guilt? Right, leading to, very high, emotional arousal, and then the problem behavior. What are the short-term and long-term consequences of that? DBT has a component that has been modified for adolescents. It's called DBT-A, and essentially they speak about walking the middle path, right? So the whole essence of dialectics is acceptance and validation, and then change, right? So this is especially useful when we're intervening with families, where it's important to sort of, tell families that, you try to just understand where your son or daughter is coming from, like, um, what is really happening for them, like, can we accept and acknowledge that they're in a lot of pain, which is why they're kind of, using certain maladaptive coping strategies, DSH, for example. And it's when they're able to sort of sit down and understand this, and accept and validate that, Marshall Linehan conceptualizes that change then becomes possible, after that. Now, one thing that, we need to remember is that, especially for adolescents, the intervention can never be targeting the individual alone. They are very much embedded in their family system. They're very much influenced by family dynamics. And so the family plays a very, very critical role. And I would say even in the early stage of intervention. So ABFT is one a model that I have personally found very useful in my practice. It's very clear. It's very clearly structured as to how to go about it. The roadmap is very clearly elucidated to, how to really go about addressing the attachment ruptures that lie at the core of family conflict. And it's a very sort of an interpersonal process oriented approach that has been spoken about, where essentially what we're doing is, to start with, is that we're preparing the adolescent and the parents for the attachment repair task. So we speak to the adolescent, we let them know that, we're going to try and look at how to bridge communication between you and your parents. We let the parents know that this is something that we're going to be attempting, how ready they are for it. And then when we're doing the actual attachment repair, we ask the youngster that, at what point did you feel that you could not share things with your parents anymore? And what would prevent you? What were the factors that would prevent this from, prevent you from sharing distress? And a lot will come out, that many different things. And then to sort of, have the parents hear this and then see how maybe, they might be able to do things a little bit differently. So this is a young person that came to mind, when I was thinking about ABFD, and she's someone I continue to see now. So she's a 15-year-old girl, who presented with, treatment-resistant depression, self-harm, suicidal ideations. She had ADHD in the background. Parents initially refused inpatient care. They even on outpatient, they didn't want to go for RTMS, and what was kind of happening was that she was alexithymic, and initially I felt that perhaps because she's depressed, she is not really able to tap into what she's feeling. But then now it also seems like more something that is trait and not necessarily just state. And so she would tell her parents that she's fine, because she was just it was too taxing for her to really kind of track her mood. And so but then if you really like spent that time, then she'd tell you about different voices in her mind, which didn't really seem psychotic. I mean, at one point I was wondering, is this kind of quasi-psychotic? But voices basically telling her that she's useless and worthless, and telling her to jump, which she knew were, her own thoughts, but she felt very compelled to act on them. And this is where, it really helped initially to sort of apply this ABFT approach to understand what were the barriers that she experienced to share her distress. So one of them were that the parents would tend to go into a very solution focused kind of a mode, very intellectualized responses, like saying life has a higher purpose, God has a plan for you. And it would seem kind of evident to me also, like when they would be sitting in front of me, that and I would kind of notice this in her mom, that her anxiety would tend to make her sort of you know freeze up, and she would not really be able to connect or offer that nurturance. And so, when we started to kind of work out all of this, then she began to communicate distress more. So the parents were able to understand more that, this is how much, pain that she is in, which led to an initial inpatient care. And then, she did respond to a ketamine, RTMS. And now, like on OP basis, some of the um, risk factors really that led to her becoming very distressed in the first place are still continuing. So so we're kind of really looking at seeing how to help her out now. I did start this young person on methylphenidate because ADHD is something that we assessed, we suspected clinically, and then we assessed it, and that is helping her now that her mood is better. But then earlier, I do recall that when I had tried it for the first time, then it hadn't really worked. There was a time when she was sort of saying that those voices are becoming more kind of prominent. She's also suspected to be on the spectrum, that is having ASD. So now we're looking at interventions to improve her pragmatic communication. This is something that, she is really holding on to, this fact that she's on the spectrum. I'm not entirely convinced, but this is something that she feels contributes to why she's been bullied, why she's so lonely in school. And so these are all things that we're trying to help her out with, in addition to continuing to work on the parent-child communication. So something for us to reflect on at this point is that what elements, in your practice have you found helpful in the initial psychotherapeutic management of youngsters with NSSI? So when they come in, then what are some of the things that you might want to do? And like the, like this person in the case vignette, where they feel that, they may be neurodivergent, but you're not entirely convinced. You feel it may be a combination of anxiety, trauma, depression. So how do we really go about this if there is a disagreement between your own clinical impression and what they would what they're kind of holding on to? If there's a difference in clinicians also, how would we sort of work collaboratively with them? And also something that I have found challenging, especially young people with complex presentations, where there's a lot going on, how do you really, so especially if you want to say treat something like ADHD, have you, run into any difficulties? Something that, I have felt is that methylphenidate, if the timing is not exactly right of treating ADHD, sometimes, like for the person in the case vignette, I think I did feel slightly pressurized initially to try methylphenidate because her mother would say, she's not able to focus, and that's why she didn't do well in her exams. She's already lonely. If she, doesn't do well, that's going to hit her self-esteem even more. Can you do something for that? And she was also pushing me, but it can really backfire. And so, how, like, what are your thoughts on, how we can really treat comorbidity, and have you run into any challenges there? So long-term management, and why I think this part of the management is really important is because, um, as many of us would have seen, it is a chronic kind of a problem, right? It is something that a person has developed as part of their way of coping with distress. And so after, initial management, we do need to look at, how we can really support them in the long term. So I've often found it helpful to transition from, a more skill-based kind of approach initially, where we're looking at, teaching them emotional regulation, distress tolerance, mindfulness with DBT, to, how do we really look at more long-term frameworks. So MBT, which is mentalization-based therapy, psychodynamic, relational frameworks to really sort of, support them over a period of time. So, hope we're doing all right for time. I won't spend a lot of time on these, but MBT is something that I personally have found very helpful in my practice. So we've had the privilege of attending both the basic and the advanced training in MBT by Dr. Anthony Bateman when he had come to India. And he's coming again to India in June, in case any of you are interested in the training. So, found it extremely useful. It's sort of modified for use in adolescents as well. That's called MBTA. And especially, the research evidence does focus on borderline personality disorder, BPD vulnerability, self-harm, and suicidality. So, the essence of mentalizing is that it's a process by which we understand our own and others' behaviors from a reading of underlying mental states. And for DSH, what they speak about is, can we fact find about the incident by using a not knowing stance, by finding the point at which mentalization went offline. So, for example, if somebody says, yeah, I just cut myself, it just happened yesterday, if we ask them, oh, why, what happened, they might not immediately be able to tell us. But if we say, okay, just, tell me about your day, like start from the morning, what happened first, then what happened, how was your mood at, so and so point in the day, who did you speak to, what were you thinking about, what were you feeling, what was happening in your body just before this incident happened, then usually we will be able to pick up on a lot of difficult feeling states. And one of those is what we call a psychic equivalence, where basically the person holds on to certain thoughts and cognitions, and considers them as being, the reality, although it may not actually be. For example, I'm ugly, everybody hates me, nobody loves me, my parents don't care about me. So very, I mean, strongly held cognitions, which can certainly, which very similar to how Dennis Ogren has spoken about core pain in his therapeutic assessment. So MBT it certainly does lend itself to long-term work. So we start out with an MBT formulation, which is something like this. Then there's a stage where it's called MBTI, where you're kind of telling a person about mentalizing, you're telling them about the different non-mentalizing modes. And then the main therapy it's designed to go on for 18 months or so. And it does actually draw from psychodynamic frameworks as well, attachment-based frameworks. there is a strong relational component which I do find very useful. So, I mean, if we look at this, it does look at what aspects from a person's past contributes to their current relationship patterns, that is their attachment. What is happening in terms of the mentalizing? When do they find it hard to mentalize? When can they easily do it? What is their mentalizing about their self, right? So, in terms of mentalizing self, is that something where they tend to go into the psychic equivalence? What about when how do they feel others mentalize about them, and how do these then lead to certain joint goals, and how might they lead to possible hurdles in working together? So, for example, somebody who is very avoidant, right, for whatever reason in their attachment or their relational style, that might lead to a potential hurdle in the therapist-client relationship. So they may not want to, open up at all. So for the clinician to be mindful of it, and if that's becoming a hurdle, to say that, okay, this is something that we worked out in your formulation, and then, how can we really look at overcoming this? There's a module called MBTF as well, which is mentalization-based interventions for families, to help families understand when mentalizing breakdowns occur, and how to interrupt them. And very often it can happen in a very heated situation, that when one family member loses their mentalizing, say a parent, that can lead to comments that are again rooted in psychic equivalence, which is, you are always lazy, which can make the person listening lose their mentalizing as well. You don't understand me, you're always nagging. And we can see that when statements like this come, they're not really reflecting. So at the heart of good mentalizing is a reflective capacity that's very flexible. So it's clearly not happening, and then that can just lead to a downward spiral. So it helps to see how this can be interrupted, and is there a member of the family who is likely to be able to mentalize reasonably well? Can their help be taken to interrupt the cycle? So this is another very useful component. So this is someone whom I've been seeing for the past 2 years or so, and it's only now that we've kind of spaced out our sessions, because she's doing a lot better. When she came, she was 16, and she would feel very anxious and distressed, and that's what she came with. At which time she would self-harm, some neurodevelopmental vulnerabilities in the form of ADHD and dyscalculia, developmental trauma in the form of bullying. She had started being homeschooled as a result of not being able to go back to school. The family environment was very conflicted as well, a lot of family pathology. Her father was very strict and punitive. I don't know if I've mentioned it here, but he was also dependent on alcohol. And she would be severely scolded by him, especially when he was under the influence of alcohol. And there would be a lot of body shaming that she's faced in the peer context, also by her family members. Um, and there was a point where she didn't exactly fit criteria for anorexia, but it was more like an eating disorder, NOS kind of a picture, and a lot of relationship difficulties as well. um, what I'm not sure about this term trauma bonding. I've actually learned it from the young people who come to me, but typically the kind of relationships she would get into are probably indicative of trauma bonding. And then in MBT, we would do a lot of work, really looking at, especially within sessions, when she would become dysregulated, really looking at what is happening for her, at the moment, using a lot of empathic validation, which is basically, validation, like not just kind of saying that I understand what's happening for you, but actually connecting it. So, I understand that, this is a time. So when somebody says something to you about your body, because of the kind of um, experiences that you've had in the past, that this tends to sort of make you feel really upset and anxious, and to sort of like link it up and then express validation, which in MBT is empathic validation, and then to make them aware about when mentalizing is in fact dropped, and then see how to sort of restore it. And she's really benefited through therapy, and hers was someone in whom I think I've used like largely an MBT approach and some sessions with the family. I know I've mentioned that here, but honestly, I don't feel that I was able to really affect too much change in the family. But I did make an attempt.
Sriyoshi,
Yeah.
it's 8:18 now. Would
Yes,
you like
I'm
to?
I'm going to I'm going to wrap up.
Yeah.
Um, So relational gestalt therapy is something that I'm training in now. Little bit difficult to explain, but I found that some components of gestalt therapy has been actually incorporated into schema therapy, which is, it's more like structured, easier to kind of understand. This is something that Young came up with, and it does have again quite a bit of research for people with BPD and with self-harm. There's a very interesting paper that I can share where specifically they look at emotional regulation for a particular client through the lens of schema therapy and also through the lens of DBT. And the focus is on really looking at working on a person's early maladaptive schemas, which are like, core cognitions, and identifying certain modes that they may be operating under. And that if we work with these and change these, then emotional dysregulation and frequency of self-harm, etc., all of those are also going to come down as a downstream effect of that. So this is kind of how they work, the different kinds of modes that are identified. So to help somebody identify if they're being very self-critical, that may be like a punitive parent kind of a mode. If to help them understand that if some of their needs as children were not really fulfilled, then even as an adult they may go into these child modes, like a vulnerable child mode or an angry impulsive child mode. And to cope with the pain that is held in these child modes, people go into they develop these kind of coping strategies. Like for one example of that would be this detached protector kind of a mode. And to really help them understand, okay, like how, like for example, the pros and cons of this detached protector mode, like in today, like in the here and now, would she sort of want to keep this or keep it some of the times or not keep it at all? So some of that work, and to see how to really access the healthy adult mode. So it does involve like a lot of chair work between the different parts. So a lot of that is gestalt, but a lot of the core schemas are again addressed through some CBT techniques. So this is schema therapy again. It is something that I know, like someone I know in NIMHANS is using it as a part of their PhD. So these are all very interesting and really like worth looking at. And the last one, and this is probably the one that I know least about, but I'm kind of trying to read and know more, is somatic therapies. So for a lot of people in whom they've experienced complex trauma and that's affecting relationships, it really somatic therapies kind of boils down to not so much of a top-down approach that we see in CBT, where you identify the thought and then the behavioral state, the emotion, and the physiological sensations go down. But it's looking at identifying what is happening in the body, and then whether that can be experienced and perhaps re-experienced, and whether that can then, serve as like a bottom-up kind of an approach. And this is something that I've kind of been trying to read about. It's very interesting. Especially I think for people who kind of go into like very dissociative kind of states where you don't have a lot of verbal material to work with, to really look at what is happening in their body and see if some of the tension can be released in certain places that they're able to identify. How does that feel for them? What does it remind them of? And do the processing in that way. Like I said, pharmacotherapy, it's if you haven't identified a comorbid disorder, that you're very convinced about, then it's a bit of a hit and miss. SSRIs I have found, because in a lot of people, with kind of these very like a chronic course of self-harm, a lot of family pathology, there would be a lot of anxiety. So, I have tried SSRIs, but very often they haven't really helped. And sometimes, a lot of the times, especially in young people, you have activation. They seem to switch. So in those situations, lamotrigine is something that I've found useful on occasion. If there's a lot of agitation, low dose of aripiprazole has sometimes worked wonders. And mirtazapine is one where, if appetite is low, if you need a bit of an effect on sedation, it's just something that doesn't activate and something that just tends to kind of calm the individual down. MPH again, I would sort of use with caution, but in some adolescents, where you're very convinced about the ADHD and uh, if the self-harm, it seem to be like very impulsive reactions to interpersonal triggers, then it can be helpful. Tonidine and prazosin more, when some of these individuals, if they have like nightmares, as a part of a complex trauma presentation, that is something that I have found helpful. Endoxifen, I actually haven't used at all, but in a few adolescents, I've been contemplating using it. But if some of you have used it and if you have any positive experience with that, I would love to hear about your experience with endoxifen. I think some of the challenges really that we face, is that often the function that self-harm serves for young people, what are they really looking for? They're looking for nurturance, they're looking for validation, um, and they get that through the self-harm, but it's not met by their immediate environment. So that could definitely lead to a lot of dependency on the treating team, and you may have issues with boundaries, and all that are things that I have found like quite difficult to work with. And many a times, you may feel that family interventions are absolutely necessary, but the young person will not allow you to even put them in the same room as their parents, saying that, I absolutely like, I do not, want to breathe the same air as them. So it can lead to us feeling really stuck. And then school authorities inevitably get involved, especially if the self-harm is something that they have noticed, and um, if like they sort of feel it's something that needs to stop immediately. We've had school counselors just calling us up in a panic saying we have to talk to you, and then that becomes really hard because it's kind of like third party communication, which is all of it becomes really 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 tricky. So these are some of the challenges that I have encountered, and that brings me to the end of my talk today. I'm hoping that,
Thanks,
I
Shreyashi.
mean, yeah, you've all been reflecting on some of the questions. I haven't been able to see what's happening in the chat
Yes,
box.
in fact, I think that there are, a couple of questions in the chat box as well. Perhaps people could, fill in a few more as we continue the discussion. But that was really, really comprehensive, Shreyashi. I think, we learned a lot about the multiple different ways of, not just understanding, but also responding to self-harm, and which I think is the greater challenge for anybody who's working with young people as to what do you say, what do you do, where are you really supposed to intervene, what is that one thing that I would have liked to reiterate a whole lot of points, but the single thing that I would definitely say is what you said about that sometimes both assessment and intervention tend to be quite dynamic and long term. So the one thing that clinicians perhaps shouldn't within the first consultation, definitely not, and probably not even within the first few weeks, because remember, these are young people, they're developing, their environments are evolving, so a whole lot of stuff is changing, right? And it takes time for us to really kind of align ourselves with that when we're interacting with them. And I think in response to one of your initial questions, somebody in the chat box had actually
Did we lose Isha or is it my connection?
Are people able to hear me?
You're back
Um,
now.
yeah.
But when you were speaking about the response to the question, I didn't catch that bit.
Okay, am I back again?
Yes,
Yeah,
ma'am.
I think so.
Yeah. Okay. Yeah, I don't know why that's happening. It shouldn't be. Okay, so I think that's what I had to basically say. Let's get on with the questions. So the first question that I saw in the chat box, Riyoshi, was about pharmacological options, and while you covered a lot of them, but the specific thing people are asking about is lithium.
Mm. Yeah. Um, okay, I think I might just take the lithium question. I think we've maybe lost Isha again a bit there.
They're just asking what about Dr. Mehta is in fact asking.
Yeah, she just typed in what about lithium?
Huh. Uh, I don't think I've used lithium very much in this population. Like if bipolarity is not clearly established, I've tended to use lamotrigine more. Like, if I'm kind of just trying to target the dysregulation, or if there's been activation or with SSRIs. Um, yeah, I used to use lithium more, I think, when I was at NIMHANS, but now in private practice, not so much. Yeah, but definitely it's a molecule that we can consider as well.
Right. Isha ma'am, is it okay if I read the questions out?
Yes, please go ahead.
Okay, just because of the patchy network thing.
Yes, go ahead.
Dr. Sreyoshi, we've got another question. It says, good evening. While I'm aware that parenting tips are often very individualized, I would love to know what kind of parenting tips beyond basic safety protocol do you think would be helpful for parents of children or adolescents with self-harm?
Dr. Neha, could you excuse me 1 second?
Sure.
I think my 3-year-old may have to join the call with us because I think she's kind of knocking on the door and trying to get in. Just
Okay.
excuse me for 1 minute.
No problem.
If I could, in the meanwhile, just add to what Sreyoshi was talking about
Yes,
in
ma'am,
terms
please.
of the utility of lithium. So DSH and NSSI is that non-pharmacological interventions stop, right? So that is the one thing that one would want to do enough of before actually deciding the molecule. And then again, perhaps what Sreyoshi was referring to is that again that there has to be enough ground for and others, talk of lithium as this anti-suicide molecule or, anti-self-harm molecule, but it's not really, a one-to-one thing. It's not that just because you give lithium, suicidality or self-harm thoughts come down. So lithium, given to a young person who's experiencing a lot of mood fluctuations where, you're suspecting is this more like a mixed state where you're getting a lot of agitation, restlessness, and, along with that, a lot of these self-harm behaviors. So I think there is a space for it, which is kind of described by the clinical patterns that you see. But one must be careful in thinking of any molecule in and of itself as anti-suicide or anti-self-harm. That's the error that we must not make. Okay, Sreyoshi, back to you. I was just filling in the gap.
Thank you. Thanks, Isha. Neha, could you just repeat the parenting question once again, please?
Sure, ma'am. It says, while I'm aware that parenting tips are often very individualized, I would love to know what kind of parenting tips beyond basic safety protocol do you think would be helpful for parents of children or adolescents with self-harm?
Um, hmm. That's a tough one. I mean, especially because I look at parenting more, like in terms of reflective parenting. So in a particular situation, how to really, if I'm doing a parent meeting and they tell me about a particularly heated kind of a conversation that was happening, check with them about what was happening, internally for them, that led them to respond in a particular way, and where did that come from, and have they found it helpful, or not, and then how would that sort of determine what they do the next time round. So that's more how I approach parenting. So I don't know in terms of a tip. um, yeah, I mean, if they ask me, like, especially working parents, if they said you need to like take, time, do I need to take time off from work? I would say, you have to just like be available. You have to, I think one thing that I have offered as a tip is just to try to notice what is happening for, their son or their daughter, and to try and check with them, like to just tune it, be more attuned. So if they're looking dull, they're looking low, they're looking anxious, to just say it and let them know that I'm here if there's something that you wish to talk about, right? So that is one, just trying to build attunement, trying to build connection time. I mean, more for younger children perhaps. And um yeah, and not to respond with too many solutions, because that is something that teenagers tend to find very annoying, when parents say, do this, do this, do this, do this. And just to kind of listen, hear their perspective, say, okay, this is where you are, and I hear you. What is the kind of help that you feel may be supportive for you? Like, so to take cues from them. Yeah. I mean, but all of it is kind of centered around the premise of, again, attachment focus and reflective parenting, but that's more how I kind of practice now. So
All right. And I think, ma'am, there's one last question. What are the ethical challenges in research in this domain?
uh hmm. I'm very tempted to just like pass on this question to Isha, because I know that she's just a much better researcher than I am. So yeah, I don't know, Isha, do you want to take that one?
Yeah. So, I mean, if I understand the question correctly, what are the ethical challenges in research? I suppose, a lot of it centers around confidentiality and, what do you really do if such a thing comes up? Whether you're doing research assessments for a self-harm related research question or for another question. So I think any risk to self or other, right? So whether we're doing clinical practice or we're doing research, any risk assessment or risk disclosure is something that, kind of falls out of the realms of confidentiality, and which is something that we write into the consent forms, consent and assent forms as well, right? So if I learn of anything that is likely to put you at risk, or, if I learn of anything that's likely to put somebody else at risk, then it is something that, I would take up further so that you can get, appropriate help and so on. That is the one, straightforward thing that, has to be built in. And in fact, ethics committees will ask you to put it down if you haven't. And, a lot of research with young people, I mean, one of the things that Sriyoshi spoke about is that self-harm is something that actually begins in childhood, right? It is something that begins during adolescence. The mean age, as she said, was around 15, 16 years old. So for all your child adolescent protocols, you must, pay attention to the possibility of this coming up. The other, I think, more a beneficence related aspect, research wise, is that, say you're doing a qualitative study, where you're really engaging with these young people, and, you get to learn a lot about them. And you might actually find that, a whole lot of assessment things that Srushi was talking about, you start looking at those windows, and you start, filling in those gaps about, the understanding of this person. So now what do you do with that information? So one of the things that you also write into a research protocol is that if there is something that you share that could potentially, help in your treatment, then, I would discuss with you about passing it on to the treating team. Right. So that's the principle of beneficence. So non-maleficence and then beneficence, both of them apply as far as, self-harm and research-related aspects are concerned. I hope that was what you were asking about.
I think we have one hand raised from Dr. Akshada.
Hi, ma'am. Good evening. Thank you for this wonderful presentation, first of all, and the nice cases which you discussed. I have a case which I would like to discuss from my end. There's this mother who comes to me, like twice she has come. First time she came in, she has an 11-year-old girl who is going to almost, I think, 6th standard or something. And this first time his mother came in saying that her daughter's behavior past 6 months, 7 months has changed suddenly. And she has seen this gradual change in her daughter post-COVID, basically. That she's not been talking to anyone in the family properly. Is mostly withdrawn. Likes to sit in her room. They don't know what she's doing, but she's always on with her phone. And the phone obviously came in after COVID when the online classes began. So now recently again she came second time, wherein she said that she just happened to see her daughter's phone without her the daughter like knowing about it. And she went through her phone and saw some messages from a boy from her class. Not any romantic messages or any love messages, but this boy is telling her about how this life is not worth living, and how it is important that we all must exit from this world as soon as possible because there's nothing to look forward to. And then the mother went on reading, and then she realized that his girl also has been like talking about suicide, researching about suicide, researching on different ways of suicide. And the mother also came to, she also has called up some suicide helpline. My mother came to me asking, how can we help her? And she's not ready to go to any psychologist or any psychiatrist, no one. She's refusing to talk to the mother completely. She just doesn't want any help from the mother. So what I did, I couldn't do anything because the patient had not come. I didn't know what exactly was happening. So I just told the mother, you pass on her number to me. I messaged her. I don't know if I should have done or not, but I messaged her saying that I am from the suicide helpline, which you had tried to contact. Would you need any help? In that also, she kept on asking me questions like, what do you think about suicide? And how do you think death should come in? And did you ever feel suicidal? I wish I played a blue whale game and I could just vanish out like from this world. So I mean, now the mother again is going to come to me to ask for the further help. I'm clueless. I'm blocked. I don't know how to help the girl. I don't know how to help the mother because she's just 11 years old, and the way she sends messages, like that only one time, like 5-minute chat I had with her, was like a very 18 or 19-year-old girl talking to me. So it's a very tough thing for me. I don't know what I'm going to tell the mother and how I'm going to help her out. Hello.
Yes. I did hear you. Thanks for that, Dr. Akshada. It's not an uncommon clinical scenario where we just have the parent, coming and meeting us, and it's either for
Hmm.
an adolescent who's, aggressive or one that's self-harming, and it's a very difficult clinical situation. But there are times when I have worked only sort of with the parent, to sort of help her understand that, in an interaction with her child, like, what would be, what does she feel, would help, for in this situation, I think she would have to sort of, confront her with some of the things that she's found, right? To say that, I'm really worried about you. And I know that I've, done perhaps not the greatest thing by intruding into your privacy, but I did it because I was worried about you, and now I'm just really more worried, and we have to sort of figure out a way to work through this together. And if she's really anxious and really overwhelmed, then these are not the words that will come out of her mouth. She'll, I've had parents say, is this what I've raised you all these years for, to kind of find this sort of thing, letting me down, you're letting us down, which is just going to drive like further downward spirals. So I think just supporting the parent is really all that we can
mother, I had spoken to her about this confrontation, but the mother is very worried that, she confronts, and what if the girl really does something that night? Because the daughter is refusing to talk to the mother at all. She's refusing to take any help from anyone. She's just shutting her door and keeping. So they're scared. The mother is not sleeping at night because she's scared that she might really do something to herself. It's a very tricky kind
Yeah.
of a situation. So I don't know. Let's see. That this time she's coming. She had messaged me saying that say some 5% improvement because she's got in touch with the teacher. The teacher is trying to help her indirectly doing something in the class and keeping a watch on that boy who is teaching her things. So let's see if that helps now. But there's nothing much we can do about this, right? I mean, the mother
No,
only has to be
very,
spoken to.
very difficult. Like, there
Yeah,
are times when parents have kind of like forced their kids to get admitted.
yeah.
And it really like starts intervention on, like we're on the back foot when we
I
start.
completely-
Then there is
yeah,
the trauma of that you have to work through before.
and what I have seen is the only cases which I have got success or responses when I have kind of sided by the child, or I have been on the child's side, and the child has actually come on his or her will to for treatment, not when the parents are forced or I am with the parents. I mean, with all of us. So obviously, this is like completely forcing her and getting will not really help her. I feel. So let's see. I mean, let the mother come in, and I'll probably know better.
Yeah, yeah. Good luck with this kid though.
Yeah. Thanks.
All right, ma'am. We are not going to keep you much longer. I think this one last question. After that, we can wind it up. Are there any scales to assess the NSSI conversion to active suicide attempt?
The only scale that I'm aware of that has been used quite a bit in research is the ISAS. So that basically looks at different forms of self-harm or self-injury, though. But this conversion, I'm not aware of a scale. No. Yeah. The ISAS is one that's used a lot in research. We used it for our MBT group as well as a pre and post intervention measure.
All right.
Okay, I think that's brings us to the end of the questions in the chat box as well. Of course, I don't know, Sriyoshi, if you would agree with me, but scales is something that I'm really wary of. In clinical practice as well, because we tend to sometimes overinterpret their utility. But having said that, the scales always help us be comprehensive. So, but it has to be interpreted in the clinical context. Okay, so well, I suppose what a delightful session that has been, and truly worth everyone's time. I think you're already getting a lot of positive messages in the chat box. So thank you, Sriyoshi, and I'm again very grateful to the organizers for having me chair the session. I hand it back to the organizers.
Yes, ma'am. Thank you so much, Dr. Sriyoshi. And I think you just wanted me to share the MBT training information. I don't know why it's in this format, but ma'am, do you want to say anything about this?
Yes. So, I mean, the person really who's brought MBT to India is Dr. Ashlesha Bagadia. So she's somebody, who I've learned a lot from. I mean, we were running an MBT group together. So when she sort of knew that I was going to do this talk today, I think she guessed that I might say something about MBT. Then she said, if, somebody's interested, just to let people know that, Bateman is coming to Bangalore this year, and he's doing the basic program in MBT on the 25th to 27th of June. So if some of you are interested, this would be a really, really great opportunity because he doesn't come down to India a lot. And your other option is to go to the Anna Freud Center, which is in London, and get trained there. Thanks, Neha. Thanks for having me today. It's really been a pleasure. And
Thank you
yeah.
so much, ma'am. It was a wonderful talk by you, of course, and a lot of great inputs by Isha, ma'am. And I will now pass on the mic to Dr. Akshada for proposing a vote of thanks.
Yes, thank you so much, ma'am. I think it was a very insightful evening. Neha and I both have done an observership at NIMHANS, and I think you were the final year DM. Then I don't remember if you had passed out, or but I mean that time also everyone would just speak about you. Like like Dr. Shreyo, she was the one to go to. I mean, to discuss any case. So it was nice to hear you here, talking on a very sensitive and a very important topic in adolescence, which we all do face a difficulty in treating. Thank you, Dr. Isha, for being a very nice chairperson who really kept a watch on time and everything. Thank you so much. Thank you, Bhave sir, for attending our program today. And I think Dr. Ritambara is out of range currently. I cannot see ma'am. But thank you so much, ma'am, for pushing us to get this speakers and having such nice programs. Thank you, everyone, for attending. Have a good evening. Thank you all.
Thank you.
Thank you,
Bye.
ma'am. Thanks a
Bye.
lot.
Bye.
I want to thank
Thank
your
you.
daughter also for cooperating in the last couple of
So sweetly
minutes.
she cited.
Or not.